Welcome back, everyone, to yet another class on pedontology. Well, today we're going to discuss about anti-infective therapy. Now, anti-infective therapy means we're going to use antibiotics, basically antimicrobials, in the management of periodontal infection. Now, what is the rationale of using antibiotics or antimicrobials in the management of periodontitis? Well, you know that in the oral cavity, if you take a plaque sample, you may find that there are about 400 or probably 500 different species of microorganisms which are present in the oral cavity at a single point of time. But we all know that all these microorganisms doesn't cause any disease. Only a few, which are known as periodontal pathogens, actually result in periodontal pathology. The rest of these are commensals in the mouth, and these are organisms that are actually needed in the mouth. But when the number of these periodontal pathogens increase in the mouth, it will cause periodontitis or different periodontal infections. So, ultimate aim of periodontal therapy is basically to remove these microorganisms. And once you have controlled or removed these microorganisms, you can control periodontal disease. But the difficulty in removing these microorganisms is these microorganisms are usually seen in a biofilm-like state. I think when we discussed about periodontal microbiology, I discussed about what a biofilm really is. Now, when you have a biofilm like that, you can disrupt by means of mechanical means. That is what we ask the patient to do, whether that is by ask the patient to brush so that they can disrupt the plaque of the biofilm, or mechanically we can disrupt by means of doing an oral prophylaxis, by means of scaling, by means of root planing, we try to remove that. But there are certain conditions in which you probably may not be able to remove these microorganisms completely, and in such conditions probably you may have to use adjuncts like antibiotics. But the problem here is when you have a biofilm like nature, you actually need a 500 times of more strength of antibiotic that should be present to act there inside the biofilm. So keeping this as a basis, we'll discuss about this topic on anti-infective therapy. Basically, we are going to discuss about the uh, role of different antibiotics or antimicrobials in the management of periodontal disease. Now, what is a chemotherapeutic agent? It's a general agent, it's a chemical substance that provides a clinical therapeutic effect. Anti-infective agents reduce by, acts by reducing the number of microbes or bacteria that are present there. And antibiotics actually destructs or destroys or inhibits the growth of selective microorganisms at low concentrations. Now, these are some terms that you have to be familiar with. Now, these are terms some of the examiners are very familiar in their viva. So you have to be familiar with all these terms. And disinfectant. Now, in this COVID terms, you have a lot of disinfectants. Basically, you are going to apply or animate or inanimate substances so that the topical microorganisms that are present on the surfaces are destroyed. That is disinfectants. And when you look at chemotherapeutic agents, these are agents that act locally or they act systemically. Now we'll go and discuss about the details. Now, when you look at chemotherapeutics as a whole, now in this is a chapter I have given a heading as anti-infective therapy. Now, in this, I'm going to cover two topics that are given in Karansa. That is, one is Chemotherapeutic agent, that is a 11th edition of cancer. Chemotherapeutic agents, periodontics, and host modulation. Everything is clubbed together. That's why I'm taking as a single topic. Okay. So here we are going to discuss about systemic administration of antibiotics. What do you understand by serial or a combination antibiotic therapy? A very important concept, that is host modulation. Another important concept, a question that is commonly asked, local delivery. And you have local delivery of antibiotics, or you have local delivery of antiseptic agents. So these are the things that we are going to discuss in this detail in this presentation today. Now, as I told you before, periodontal disease is infectious. It is caused by microorganisms. And basically, in most of the cases, you try to remove this microorganism by means of mechanical means. But there are certain cases in which you may have to use antibiotics as an adjunct. Example, a very good example is a condition of aggressive periodontitis. In aggressive periodontitis, the problem is these microorganisms does not remain within the gingival sulcus. These may be present within the gingival tissues also. So even if you remove mechanically all the microorganisms within the gingival sulcus, you still have microorganisms within the gingival tissues, which you may not be able to remove by means of your local debridement, that is scaling or root planing. So in that case, you probably have to give a systemic antibiotic or antibiotic that is present locally at that point, so that it acts on the microbes that are present in the tissues. And usually, you just don't give an antibiotic just like that. You are supposed to do an antibiotic sensitivity test, and you do a culture test, and then you look at the sensitivity of the microorganism to a particular antibiotic, and based on that, you prescribe an antibiotic, and you prescribe an ideal antibiotic. Now, what is an ideal antibiotic? Now, to date, let me say that there's no ideal antibiotic for periodontal infection. You can say that one single miracle drug is there by which you can eliminate all periodontal pathogens. No, but there are some features that should be that antibiotic should have, so that you should say that it's an ideal antibiotic. What are they? It should be specific of periodontal pathogens. It should be allergenic and non-toxic, substantiate. That's if you apply there in in a particular environment, it should act for a long period of time. It should not be in general use for other treatments, other diseases, and it should be inexpensive. As I told you before, we still don't have an ideal antibiotic that is effective in all cases of periodontal infections. So how do you base your prescription? As I told you before, no single antibiotic will not inhibit all periodontal pathogens. So basically, you may have to combine one or two or one or three antibiotics, so that you have the cumulative effects acting together, so that it can control the growth of periodontal pathogens. And your prescription of an antibiotic may be based on the following things: the clinical status of the patient, whether he's having any systemic problems, systemic diseases. What is the nature of the colonizing? Is it gram-positive bacteria, gram-negative bacteria, is a motile bacteria, is it a spirochete? And what are the risks and benefits associated with the proposed treatment plan? So when you incorporate all these into your in your clinical acumen, and then you prescribe a particular antibiotic that should be good for that particular patient. That is basically what you do. And look, in pharmacology, you would have come across all these agents. Now, all these agents have to be done in detail, but I'm just rushing through that because all these agents you have studied in detail. That's the reason. Now, you have different types of penicillin. Amoxicillin is a common penicillin. augmentin. The augmentin is an antibiotic that is widely prescribed in periodontitis. And the reason is, it acts against penicillinase because apart from amoxicillin, you have clavulanic acid, which acts against penicillinase. Then the different forms of tetracyclines, minocycline, doxycycline, and oxytetracycline, quinolones, macrolide derivatives, lincomycin derivatives, and nitroimidazole. You all know that these periodontal pathogens are mainly anaerobes. So metronidazole is a common drug that we usually give in the management of periodontal disease. You actually have to know the dosage of the drug and the duration uh, each drug is given. Now, again, I'm not going to detail about all these because all this has been covered for you. Now, when do you decide? Do you have to give antibiotics in all cases of renal disease? Do you have to prescribe an antibiotic for a gingivitis? No. Do you have to prescribe an antibiotic for a periodontitis, chronic periodontitis? Absolutely no. Do you have to prescribe an antibiotic for a periodontal abscess? No. If it is a routine periodontal abscess, no. But there are certain conditions associated with the periodontal abscess, probably a systemic problem. Okay. In such cases, only you prescribe antibiotics. And one common case where you prescribe antibiotics, one common periodontitis case where you prescribe antibiotics is aggressive type of periodontal disease. As I told you before, here in aggressive type of periodontal disease, you have colonization of these microorganisms into the periodontal tissues, which you cannot remove by means of mechanical means. So, as an adjunctive measure, you probably have to prescribe an antibiotic. Now, this is a flow chart by which you can prescribe. You decide whether you need to do antibiotics, and if at all, what you do is whenever you have to do microbial analysis. Everything is being discussed in this chart. Now, next thing, what we should discuss is what is serial antibiotic therapy and what is combination antibiotic therapy. As I told you before, no single antibiotic. We don't have a magic pill to treat periodontitis. So you need to combine different types of drugs. So, and it is also a mixed infection. So there are certain rules when you give antibiotics together. One is you should never combine a bacteriostatic agent with a bactericidal agent. That is, you should never combine tetracycline with an amoxicillin. Both are effective, but you should never combine them. Now, when both are given, both are needed, give it serially. Now, first, you can start with tetracycline. Okay, you give it for one course of tetracycline, probably about 5 to 7 days. Then, after that, you start with amoxicillin. That is known as serial antibiotic therapy. Now, the principle in serial antibiotic therapy is you should never combine a bacteriostatic with a bactericidal drug. Now, what is a combination antibiotic therapy? Now, if it is not a bacteriostatic and bactericidal, probably you can combine. And there are umpteen number of studies which shows that a combination of metronidazole and amoxicillin is very effective in the management of periodontal disease. And also, you can come to a combination of metronidazole and ciprofloxacin. So these are combinations you can give. It addresses all the different bacterial spectra which can result in periodontal disease. That is a basic idea. So you should know what is serial antibiotic therapy, what is combination antibiotic therapy. Then we come to important aspect. This is actually given as a separate chapter for you in Karansa. Post-modulation. Now here, this is a treatment concept. Now, to understand post-modulation, you should first understand how periodontal disease occurs. We all, I think the topic on periodontal pocket would have been discussed for you. Now, what happens, or we'll just discuss briefly how periodontal disease occurs. Now, actually, if I suppose a patient doesn't brush his teeth properly, or suppose there is more and microbes accumulating in the oral cavity, what they do is they start producing a lot of mediators. And against these mediators, what happens is these neutrophils, they migrate out of the blood vessels. They come out through the sulcular epithelium into the gingival surface, and they neutralize these microorganisms. That is what happens in normal state or in the early stages of gingivitis. But in the advanced state, when more and more of microorganisms are present, and more and more of uh, what do you say mediators produced by these microbes are present, they may actually initiate what is called as an intraepithelial pocket, whereby the junction within the junction epithelium, the junction epithelium will start receding slightly. That is an intraepithelial pocket. And as a result of when that recedes apically, what happens is for it to recede apically, the collagen fibers as well as the bone should get dissolved. So as a result of different agents, the interaction between the, the host and the bacteria, the bacteria will produce a lot of agents, destroy the host. The host will produce a lot of mediators to control the bacteria. But the problem is these mediators that are produced by the host not only destroy the bacteria, but they produce resident damage to the periodontal tissues there. And this is known as bystander damage. So the host actually is trying to control the bacteria there, but at the same time, the host destroys the bacteria, but because of the different mediators produced by the host, they produce a lot of host tissue damage also. So that is where this host modulation comes. So in this host modulation therapy, this is a specific type of therapy in which we are trying to downregulate the protective aspect of the host and upregulate the regenerative aspects of the host. Okay, so you are modifying or down-regulating the destructive aspects of the host, upregulating the protective aspects of the host. This host modulation. Now, this is a new paradigm. This is not a new paradigm. This is way back in 1997. This was proposed by Conman. According to this, here in this area, you have bacteria, and there is a host, as I told you before. So there is the interaction between the host and the bacteria over here. Bacteria produce a lot of virulence factors, and these virulence factors are mainly lipopolysaccharides. And in stimulation to these lipopolysaccharides, the host produce a lot of mediators. Maybe either cellular mediators, like means of different types of cells, neutrophils, lymphocytes, macrophages, plasma cells, all these cellular mediators, or humoral mediators, that means of different types of antibodies that are produced. The basic idea of this cellular humoral immunity is to kill this bacteria. But as a result of, but they not only kill this bacteria, but they also cause the resident damage to the tissues that are present there. So you have a lot of enzymes and mediators which actually cause disease. Now, what are the enzymes? You have matrix metalloproteinase that is formed. You have collagenases that is formed. What does it do? These matrix metalloproteinase and collagenase actually destroys the collagen. When you look at periodontal tissue, the gingival tissues or the periodontal ligament, it's mainly made of collagen. So that collagen is being destroyed. Now, when you look at different types of what you call the prostaglandins are produced, what does prostaglandin do? Prostaglandin will destroy the bone there. So alveolar bone is getting destroyed. So the gingival, all the periodontal tissues are being destroyed by these mediators are produced by the host as a result of host interaction. And you have acquired and environment risk factors or genetic risk factors which may interact and influence this host bacterial interaction. So this is the new paradigm. So here what we are trying to do is we are trying to reduce the host, exaggerated host response that is present there. We are trying to control the host so that that destruction from the host is being reduced. So we we just modulate the host in such a way that probably what are the excess that is produced is being used or is being combated by means of certain drugs that we give. So that is the basic idea of host modulation. So this is the rationale for use of host modulation. You are treating the host side of the host bacterial infection. All of the treatment, your antibiotics that we give, your mechanical debridement that we do, we are treating the bacterial aspect of the disease. But this is the only concept where we are treating the host aspect of the disease. And we now know that it is not the bacteria that is mainly responsible. It is mostly in types of aggressive or in types of rapidly progressing type of periodontal disease. The host, if there is some problem with the host, and that host response is mainly responsible for a lot of dysfunction that takes place. So, by host modulation therapy, you are giving certain drugs. By these drugs do not switch off the inflammatory response completely, but they reduce or eliminate the pathologically elevated post-inflammatory response. So that is what we try to do by means of host modulation therapy. These mediators like collagenase, by means of interleukins, by means of prostaglandins, they will cause resident tissue damage. So we will control these mediators that are produced by the host, or even if these mediators are produced, we try to give some pharmacological agents by which we are neutralizing them. That is the basic concept of host modulation therapy. Now, this can be classified as systemically administered agent and locally administered agent. Basically, locally administered agents are agents that are applied on the root surface or on the tissue during surgery. Systemically, you usually give it as oral. And when you look at systemic agents, these are the most commonly used agents. You have a lot of NSAIDs, that is non-steroid anti-inflammatory drugs, or you have bisphosphonates, or then there is sub-antimicrobial dose doxycycline. Now, what does NSAIDs do? Now, we all know that NSAIDs will control, they reduce inflammation or pain and inflammation by what? How does it act? They act by reducing the synthesis of prostaglandin. Now, how is prostaglandin formed? Prostaglandin is formed by means of the arachnoidic acid metabolism. And this arachnoidic acid metabolism occurs by means of two pathways, which is known as COX-1 and COX-2. Now, the prostaglandin that is formed as a result of COX-1 pathway is very much essential for the basic needs, daily, day-to-day needs of our body. It is needed for the thrombogenic and cytoprotective actions within the body. The COX-1 is very needed. The prostaglandin produced by COX-1 is very much needed for the body. But it is the prostaglandin that is produced by COX-2 pathway that is actually causing this disease or causing this exaggerated response, which can result in alveolar bone loss. So we try to give certain agents, certain NSAIDs to block this COX-2, specifically this COX-2. So what are the agents? The common agents that has been used is flubriprofen and naproxen, and different varieties of flubriprofen and naproxen have been tried. But these, you can, these agents you just give in single dose, they won't have any effect. You have to give for months. Now just imagine giving NSAIDs to a patient for months or probably years. It has got a lot of side effects. So more than the potential benefits associated with this modulation, may have a lot of other side effects. So nowadays we don't use that. It's just of academic interest. So you should know NSAIDs, why it is used. It is basically you are trying to reduce the prostaglandin that is formed by COX-2 pathway. What are the agents that have been used? Naproxen, flubriprofen. Another agent that has been tried is bisphosphonates. Bisphosphonates are actually, when a patient is having osteoporosis, usually bisphosphonates are given. They are bone-seeking agents. which actually inhibit bone resorption. They basically disrupt the osteoclastic activity. So it is the osteoclast that causes bone resorption. We all know that. So this osteoclastic activity is being disrupted by giving bisphosphonate. So this mechanism, this theory is being used so that we use this bisphosphonates in controlling bone resorption, phenol disease. And also they possess one property called as anticollagenase. This offers an additional benefit of anticollagenase activity. And the drug that we have tried is bisphosphonate that has been clinically tried is known as alendronate. And another drug that has been tried is palmidronate. So these are the two drugs that are commonly used. Bisphosphonate that has been given as post modulation therapy. Okay. Third and the most common post-modulation therapy that is clinically available also is known as sub-antimicrobial doxycycline. Now here what you do is you are using a 20 milligram doxycycline. Now you all know that usually we give doxycycline as a 100 milligram tablet for its antibiotic use. Now initially you load it as a 200 milligram. The first day you give 200 milligram dose and then the following days you give 100 milligram dose. But here when you're using as post modulation therapy, you give a 20 milligram dose, one in the morning, one in the afternoon, and you give it for a period of 3 months to 9 months. Now, at the 20 milligram, it does not have any antibiotic effect. The effect it has is it can inhibit the formation of matrix metalloproteinase. And which matrix metalloproteinase are we talking about? The matrix metalloproteinase that is causing major periodontal destruction is the MMP8, the matrix metalloproteinase 8 that is produced by neutrophil. So specifically when you give this doxycycline cyclate 20 milligram, which is commonly known as periostat, so when you give that, it will block the matrix metalloproteinase 8 that is produced by the neutrophil. So that is, you have different types of MMPs. Specifically, we are going to block this MMP8 that is produced by the neutrophils. So that is the basic idea of giving some antimicrobial doxycycline. So the collagen dysfunction, as I told you before, the collagen is the main content that is present in periodontal tissues of the periodontal ligament, the gingiva. So that destruction you're going to control by means of giving this periostat 20 milligram dose. Then locally administered agents, this, as I told you before, this NSAIDs can be given topically, or you can give growth factors, PMPs, endogain. When we discuss about penile regenerative surgery, we will discuss about endogain. Endogain is you can say it's a growth factor. It's nothing but it's a camel matrix protein, which is of porcine origin, which actually stimulates the formation of acellular cement. So that is also given alongside surgery, so that you can reduce the post effects. Next is local delivery of antibiotics. So first we discuss about systemic antibiotic therapy, the different types of antibiotics that can be given orally, systemically, or even as injections. Then we discuss about serial and combination antibiotic therapy. Third, we discuss about post-modulation therapy. Now we are going to discuss about local drug delivery. When you talk about local delivery, it can be either local delivery of antibiotics or it can be local delivery of antimicrobials. Okay. So first we'll discuss about local delivery of antibiotics. Now, what is the rationale of giving local delivery of antibiotics? Now, when you give systemic antibiotics, the problem of systemic antibiotics is for periodontal infection. Obviously, we are using these drugs for periodontal infection. The periodontal infection is present within the mouth, within the limited area. But when you give an antibiotic orally or parenterally, this is going to go all through your body, and it will have different effects on different organs of the body. There are a lot of side effects associated with that. Another thing is you need a large dose of this systemic antibiotic so that it should have an action in the oral cavity. So now what the investigators thought is, why not deliver these antibiotics just to that periodontal area. Now, when in periodontal area means there is periodontitis, there is always pocket. So why not develop a delivery system so that you place it within the periodontal pocket, and from within the periodontal pocket, these drugs will slowly come out and reach out, and over a period of time, it will act on that. It will provide high concentration of this drug at that particular area without much systemic effects. So that is a basic idea of local drug delivery agents. And this is the rationale of using local delivery agents. Now you have different types of local drug delivery agents. One is tetracycline-based products. We discuss about which all tetracyclines are used. Then second is something we have a doxycycline, again different forms of tetracycline. Minocycline, subgengial moxifloxacin is used, and also metronidazole. So these are the different metronidazole. The first four is antibiotic. The last metronidazole is an antiseptic. Sorry, all these are antibiotic. Metronidazole is an antibiotic. Now finally, in local delivery of antiseptics, you have fluoroxyl. All these are antibiotics. Now first we'll discuss about fibers, tetracycline containing fibers. Now this was the first marketed local delivery system that is available in the world. Now this consists of, I don't know whether you have come across this gingival retraction cords. Now gingival retraction cords are small, like floss-like thing. You will have seen a floss definitely. So these floss-like things, what you do is, just before you take an impression for a crown of bridge, after you prepared a crown of bridge, you put it within the gingival sulcus for a period of time. And then you just take it out from the gingival sulcus so that this gingiva retracts a little bit, and you take an impression. So similar to that, if you have threads into which this drug is incorporated. Now, such system is known as a tetracycline fiber, containing fiber. Now, the first marketed one, the trade name was known as Acticite, and it was made up of 0.5 millimeter EVA fiber. EVA fiber is ethylene vinyl acetate fiber. And when you take 9 inches of that fiber, it contained 12.7 milligram of drug. Tetracycline was that 12.7 milligram of tetracycline in 9 inches. And when you place this fiber in a periodontal pocket, concentration of tetracycline that we achieved within the periodontal pocket was more than 1,300 microgram per ml. And when you look at the MIC, what is MIC? MIC is minimum inhibitory concentration. And when you look at MIC for periodontal pathogens, it is just 32 to 64 microgram. But when you place this active site within the periodontal pocket for a period of 10 days, it is going to give a concentration of more than 1,300. So probably about, what do you say, about multiple times the concentration that is needed. But when you look at the last point in that slide, you give the same drug, tetracycline, 50 milligram, 4 times daily for 10 days. What is the concentration that you achieve within the gingival sulcus in the GCF? It is 4 to 8 microgram. What is the MIC that is needed? 32 to 64. So you are giving, when you give systemically, you are giving a large amount of drug, but within the gingival sulcus or within the area that is needed, you are not getting sufficient quality of drug. So when you give these fibers, when you place these fibers, you get a concentration that is much, much above that is needed, what is actually needed. So that is a basic idea of these local drug delivery agents. Now, you place these fibers, but there are certain disadvantages. These EVA fibers never resolved. One, to place these fibers into a periodontal pocket around a single tooth all around, it usually took around 10 minutes. So just imagine if you have 30 people, how much time is needed to place a all down. The time was one problem. It's not bioresolvable. Then if you place in multiple days, especially about more than 12, it can't be assisted. So that is another. So when it is not resolvable, you have to recall the patient probably up to 1 week or 10 days of having to put this EPA fibers. So that is a disadvantage, although it had a lot of advantages. That is basically you achieve very good concentration, much above the MIC. Now, this is what I said. This is the tetracycline impregnated coat, the EPA fiber. Now, just using a plastic instrument or this instrument, you just place it within the pocket. The normal gingival circle is very difficult, but when you're talking about pockets about probably 6 or 8 millimeters, you can place it. You can hold it very much inside the pocket. So these are EPA fibers. Now, what are the other tetracycline-based products? Now, these are products that are probably available in India. One is called as PERIODONTIcs. TC. Then it contains fish type of collagen type 1 that is developed from fish. And this collagen is impregnated with 2 milligrams of tetracycline. And when you place this type of collagen, the advantage is it is resolvable and you have sustained release for about 8 to 10 days. Then another delivery system that is available in India is the Photodynamic plus AB. Again, you have this 2 milligrams tetracycline, the same concentration. Now, the advantage here is it is not fiber, it is a strip. You can place it like a fiber, like a tetracycline, you can place, you have individual strips so that you place it all around the pocket. Again, this biodegrades, so you don't need a second appointment for removal, but you get very good concentration of this drug within the others. Second system, so we discussed about the different tetracyclines. Now we are discussing about doxycycline. Now you have 10% doxycycline in a gel system using a syringe. And the trade name for this is known as Dox. Now the trade name for tetracycline impregnated fibers was Actisite. The other one was Periopol. The other one was Pedron plus AP. In doxycycline, you have 10 milligram doxycycline and it's a syringe. It's known as Etridox. This is a syringe. So usually, it's very easily you can just inject it within the periodontal pocket. Minocycline. Now you have sustained release form of minocycline. The concentration is 2% of so 2% of minocycline microsphere. And mind you, the trade name that by which it is available is known as Arrestin. Why I'm specifically substantiating or emphasizing on these trade names are because, for example, for Viva, all these are commonly asked. Now here the minocycline is encapsulated into bioresorbable microsphere, which is in a gel carrier. Now this is the minocycline system. Then we have metronidazole. Now this is commonly known by the name of elizole, and the concentration of metronidazole here is 25%. And you have glyceryl monooleate and sesame oil. The advantage of this is, when you inject this, it is liquid form, but when it absorbs heat from the body, it solidifies there. So it forms crystals and remains within the periodontal pocket. That is an advantage of this sublingual metronidazole, which is known as elizole, where it contains metronidazole 25%. Then the last part, that is the local delivery of antiseptics. So we discussed about local delivery of antibiotics. In antibiotics, we discussed about tetracycline, metronidazole. We discussed about doxycycline, minocycline. Now, in antiseptic, you have fluoxetine. Fluoxetine can be in the form of a gel or form of chip. And when this is in the form of chip, commercially, the trade name is, it is known as Perio chip. And this chip is made up of biodegradable hydrolyzed gelatin matrix, which is cross-linked with glutaraldehyde. And the concentration of drug Chlorhexidine that is present in this chip is 2.5 milligram of chlorhexidine, and it acts. It gives a concentration of 100 microgram per ml for a period of 7 days. The advantage here of perio chip is it's biodegradable. You don't have to recall the patient for a second appointment. Now this is a chip. You can see the chip. Okay, you place that chip into the pocket. You can use a tweezer and just insert this chip. It will stay there. If it doesn't stay there, if you feel that it will come out, then you can place a phenol patch as an option. Then you have sublingual chlorhexidine gel, and this is commercially available by the name of Closite, and you have 1.5% of chlorhexidine when you take about 0.5 ml of gel. So Closite. So that is a sublingual chlorhexidine gel. So we have actually come to the end of the different types of antibiotics that can be given, or anti-infective agents that can be given to control periodontal disease. So you can give antibiotics as a systemic agent. You can give antibiotics as a monotherapy, serially, or as a combination. You can give antibiotics to control the post, which is known as post modulation, and to make more effective use of these antibiotics, you can place these antibiotics as different systems, sustained release systems within the periodontal pocket, which is known as local drug delivery agents, which can be either antibiotics or antiseptics. There's one more thing which is left out, and which is known as antimicrobial photodynamic therapy. Now, all these therapies that we use, I told you before, periodontal diseases and infectious disease is caused by microorganisms. Basically, you can either mechanically remove all the microorganisms, or you have to use adjuncts by which you can reduce the count of these microorganisms. One is use of different types of antibiotics. Another is called as photodynamic therapy. Now, basically, in photodynamic therapy, what you do is, if you have a periodontal pocket, you inject certain dyes into that periodontal pocket. Now, these periodontal pathogens, they will absorb these dyes. So once you wait for a period of time so that these dyes are absorbed by these microorganisms, then you activate these dyes. These dyes can be activated by light of a particular wavelength. You have different types of dyes, and different types of dyes have got different wavelengths by which it can get activated. So you activate these dyes by means of the particular light, and when it is activated, what happens is there is release of reactive oxygen species, mainly singlet oxygen, and this singlet oxygen will act on that bacterial cell and it will kill the cell. So that is the basic idea of antimicrobial photodynamic therapy. So it has three key ingredients. One is photosensitizer. As I told you before, you have to inject into the periodontal pocket. Now, it is commonly used photosensitizers are the methylene blue and the toluidine blue. Then light of appropriate. It can be a laser. Commonly we use lasers of different wavelength. Probably there are lasers that have been developed specifically for photodynamic therapy also, or you can use an LED. It should have a substance wavelength. This wavelength of light or laser should activate the photosensitizer. What does a photosensitizer do? These microbes, when you place these within the periodontal pocket, microbes uptake this photosensitizer. So when you apply the light over there, they get activated. The sensitizer gets activated. They will produce oxygen. So oxygen should be, all these should be present in the presence of this molecular oxygen. Then only it will result in the formation of reactive oxygen species or singlet, mainly singlet oxygen, which will lead to the breakage of the cell wall, which will cause that. Now this is basically, so if you have a periodontal pocket, first you have to do a debridement, scaling or rotating, curettage, everything can be done. Then you inject this dye within the peron. In what happens is, whatever microorganisms that are present here in this pocket, they will take up this dye. Okay, and then you apply light, probably a laser light, and this laser light will activate the dye. It will cause the release of this reactive oxygen species and will kill the bacteria and cause reduction of the pocket. So, thus we have actually come to the end of this topic. Basically, anti-infective therapy. Now, what is the reason why, or what is the basis on which you prescribe antibiotics for periodontics? You don't routinely prescribe antibiotics only in certain conditions. Only in cases of aggressive type of periodontitis, you prescribe antibiotics, basic, other than due to some other systemic problems. In this, you prescribe antibiotics basically because you can't remove, by means of mechanical ways, you can't remove the microorganisms with the periodontal water because some of the bacteria have already penetrated within the gingival tissue. So to kill this bacteria within the gingival tissues, probably you will have to apply locally some agents within the mucus, or you have to load systemically. There are some disadvantages associated with systemic, so you prefer for a local therapy. Thank you. Thank you for listening. Thank you.